Well, welcome everybody to today's continuing acid-base conference. The title is a little bit of a misnomer because I'm going to start today talking about some mixed acid-base disorders. But we'll start off again just reviewing what we've talked about before, where when you're making an acid-base diagnosis, you first look at either the total CO2, which you get with the rest of the electrolytes, or a bicarbonate concentration, which is calculated from the blood gas. It could be a venous bicarbonate or an arterial bicarbonate. They're a little bit different. And usually the total CO2, as we said before, is about 1.3 millimoles, 1.2, 1.3 millimoles per liter higher than the bicarbonate because it also includes dissolved carbon dioxide. It also includes carbonate and carbonic acid, but those are in the micromolar range, so they don't affect the total concentration in the millimolar range that we use clinically. So again, we look at, let's say we have a venous or arterial blood gas, and we now focus on the bicarbonate from there, and we decide, is it decreased, normal, or increased? If it's decreased, it's one of three acid-base diagnoses. It's either a metabolic acidosis, acute respiratory alkalosis, or a chronic respiratory alkalosis. And again, we distinguish the three of them, not by the bicarbonate per se, but by what the PCO2 has changed by. So we compare the change in bicarbonate from normality to the change in the PCO2 from normality. And each of these three things has a different ratio of the two. So if it's metabolic acidosis, for every 1.2 fall in the bicarbonate, the PCO2 changes by about 1. It's roughly 1 to 1. You don't have to be that precise. In acute respiratory alkalosis, it's the PCO2, which is the initiating event. So for every 10 decrease in the PCO2, the bicarbonate falls 2. And for chronic respiratory alkalosis, the bicarbonate falls further. Beyond the initial 2, it falls another 3, such that the total fall is 5 for every 10 fall in the PCO2, or you can remember 2 to 1 if you want, or you can remember that the bicarbonate decrement is about half of what the PCO2 decrement is. Or the bicarbonate could be increased. If it's increased, again, one of three choices. It's either a metabolic alkalosis or acute or chronic respiratory acidosis. And again, we don't use the bicarbonate value to distinguish the three. We look at the PCO2 and compare the change in the PCO2 to the change in bicarbonate. And again, each of these has a different proportionality, and that's how we distinguish them. Once we have a diagnosis, we divide them up further. Now, again, the respiratory acidosis and alkalosis, we've already divided because they have a different rule. Metabolic acidosis or alkalosis have two additional subtypes. Both have the same PCO2 change to bicarbonate change, and we divide them up by an additional criteria. Metabolic acidosis, we divide by anion gap, and metabolic alkalosis, we divide by whether the patient will respond to giving chloride or not. And we don't do the experiment of giving chloride. We actually measure the urine chloride or the fractional excretion of chloride. And if it's low, it tells us that the patient will respond to chloride containing salts. And as I say, it's chloride, not sodium, because if you give sodium without a chloride anion, you don't get the correction. It's the chloride that's causing the correction, as we talked about. So let's go to another patient now. This is a 36-year-old male with anxiety. Here's the electrolytes. Of note, the total CO2 is 23. Once you get used to looking at these numbers with a fine-tooth comb, you won't call that normal. When you first start your fellowship, you go, oh, 23, that's normal. But if you do a large population of males, you will see that 23 is not normal. Now, unfortunately, when you look at the lab slip or what comes back on the computer, it gives a very wide range, which doesn't represent scientific normality. It's not the truth. For some reason, these labs give a very wide range for not just total CO2, but for all lab values. But when you do populational analyses and actually look at the numbers, Jeff Crouch just had a recent large study looking at many patients and showing what the range is in total CO2. Again, that assumes you're at sea level, right? Because when you go to higher and higher elevations, normal people have a chronic respiratory alkalosis, so the bicarbonate's not going to be what it is at sea level. But assuming you're doing this kind of study at one elevation, and in this particular example, sea level, so that you don't have hypoxia, then the total CO2 in a male really should not get down to that low normally. And you can see the bicarbonate also is lower than normal. 22 is not normal. Now in a female, 22 and 23 may be normal, as we've talked about a number of times. So then the question is why? Well, again, it could be metabolic acidosis or acute or chronic respiratory alkalosis. So how do we distinguish? Don't, like you did as a medical student or resident, look at the pH and go, oh, this can't be metabolic acidosis because the pH is high. If you take that route, you're going to miss mixed acid-base disorders. So after looking at the bicarbonate and deciding is it up or down and what the three choices are for each, you look at the PCO2 and then calculate the change in the PCO2 from normality versus the change in bicarbonate, see if it fits into one of the three. So the question is, if the bicarbonate fell by, we don't know the original numbers in this patient, so we'll have to assume population normal numbers, which in a male would be 24, 25, and the PCO2 would be around 40. So the PCO2 fell by 20 and the bicarbonate fell by, let's say, 3. So the question is that compatible with a metabolic acidosis? It's compensated, and it isn't, obviously, because either whether you use the Winter's formula or you use the 1-to-1 rule, the change in the PCO2 far exceeds the change in the bicarbonate. So this cannot be a compensated metabolic acidosis. Could it be acute or chronic respiratory alkalosis? And again, if it's not one of the three, you have a mixed disorder. So you first want to check the three that it could be. Could it be acute respiratory alkalosis? Well, the rule is for every 10 fall in the PCO2, the bicarbonate falls 1 to 2. And the answer is yes, it could be. The change in the bicarbonate's 3 for 20. That means 1.5 for every 10. And that's what you would expect if you just acutely hyperventilated. Could this be chronic respiratory alkalosis? No, because the change in the bicarbonate should be half of what the PCO2 changed by. The bicarbonate would have to be about 20, assuming it started at 25. It would have fallen another 3 from what it is now. So the numbers best fit acute respiratory alkalosis. Does anyone have any questions about that train of thought or how we analyze that? Okay. So again, remember, in the acute respiratory acid-base disorders, you don't need organs to get the change in the bicarbonate, whether it's increased or decreased. In this case, it's decreased. The reason for the bicarbonate changing is not something an organ did. The bicarbonate is changing solely because you've shifted the equilibrium of the bicarbonate of these reactions here that include bicarbonate. So when you drop the PCO2, here you create a disequilibrium and everything shifts to the right and you consume bicarbonate, and that's why it falls. And empirically, given all the other buffers in the body, it changes for every 10 millimeters of mercury falling in this falls by about 1.5. Now, again, as I talked about last week, people get confused. They go, why does anything happen? Isn't the proton also consumed equally? Shouldn't the H plus decrease by 1.5 or 2? And yes, if this was the only reaction in the solution, if you had water with baking soda or sodium bicarbonate only, yes, this would occur. But you have many other buffers and they release protons. As soon as the proton gets consumed, the other buffers start releasing their protons. So this hydrogen ion concentration hardly changes at all. And again, remember, this is in the nanomolar range. If this changed by 1.5 millimoles per liter, your pH would be 14. Obviously, that can't occur. The changes we see physiologically in the hydrogen ion concentration are in the nanomolar range, and we're talking about millimoles per liter changes in bicarbonate. when we assess acid-base disorders in patients. So this hardly changes, because by this reaction, the bicarbonate buffer reaction is not the only reaction in the buffer reaction in the body. You have DNA that combine protons, amino acids combine protons, phosphate combine protons, albumin combine protons, hemoglobin combine protons. There's a lot of buffers in the body. And so all of their equilibria shift also when you shift this reaction. And they tend to normalize the hydrogen ion concentration independent of what's occurring here. So again, this would occur when you open up a bottle of Coca-Cola. This has nothing to do with the kidney. Now, the kidney, if you drop the PCO2, after this initial reaction that occurs due to this bicarbonate buffer reaction in an aqueous solution, and then you follow the patient over time, it doesn't stay there. It doesn't stay at the 1.5 decrement for every 10 fall in the PCO2. It falls further. So the question is why? It can't be due to the bicarbonate buffer reaction. That occurs seconds to minutes. Something else is causing the bicarbonate to fall, and that's what requires kidneys. So it depends whether you're talking about humans or other animals. People have studied why the bicarbonate has fallen beginning in the 1960s. Beautiful papers, if you want to read them, by Schwartz and his colleagues. And it depends what species you're talking about. In dogs, it looks like it's not bicarbonate being lost in the urine. It's not like a proximal RTA. The kidney doesn't shut off its bicarbonate reclamation, at least to any great extent. It seems to be a decrease in new bicarbonate generation by the kidney. Remember, I showed in a previous talk that the kidney has to match your daily hepatic proton load from your diet. So on an average North American diet, the diet's making about 70 milliequivalents per liter of hydrochloric and sulfuric acid from the amino acids you eat in the meat and fish and other proteins. And so that can't be allowed to occur without something happening. And the kidney generates a new bicarbonate above what it reclaims, above what it resorbs from the glomerular filtrate. It generates additional bicarbonate that matches that daily hepatic proton load. And it looks like that generation is shut off when you drop the PCO2. We'll talk about why that might be occurring at another time. In humans, it looks like, and there haven't been a lot of studies, some of these studies were done by taking people up on top of mountains and looking at the generation and the maintenance of the metabolic or the chronic respiratory alkalosis, measuring what happens in the urine. It looks like there is some bicarbonate loss in humans, but it really hasn't been worked out. And it's not pleasing to think that humans have a different response than other mammals do. Perhaps it was the hypoxia also playing a role, but one would think just intuitively that the renal response would be the same, given the fact that the physiology and the transport processes are no different in a dog or any other mammal than a human. But be that as it may, empirically, if you drop the PCO2 suddenly and then just keep it there at that new level and follow a patient, either by measuring repeated venous gases or arterial gases, or if you have them, or getting the whole chemistry panel, you will find that either the total CO2 or bicarbonate continues to fall, but then it stops falling. Remember, we're not changing the PCO2. We're keeping it at that original level. Let's say in the patient we just showed now, it would be dropped from 40 to 20 and kept at 20. We're not continually changing anything with the ventilation. We've dropped it suddenly and kept it there. The bicarbonate falls over a slower time course until it reaches a new steady state. And we have a medical clinical term for this acid base change, and we call it chronic respiratory alkalosis. Now, remember, we don't have a term for anything in between. We could. It's a continuum. We just have a term for the beginning that we call acute respiratory alkalosis, and we have a term for the final steady state value that we call chronic respiratory alkalosis. We do not call this process a compensation. We never use the word compensation in the respiratory acid-base disorders. We only use that English word when we're talking about metabolic acidosis or alkalosis. So don't talk about, you can talk conceptually that this, at least as far as understanding what's going on, you can say this is a compensatory response. But when you're conveying the acid-base diagnosis, don't call this a compensated respiratory alkalosis. It's just not a term that we use. We could have used, it could have evolved that way, but it just didn't. We are left with a temporal subdivision, acute and chronic. And again, we don't have a name for anything in between. We don't call this subacute or subacute. Now, remember, if you come along here, let's say someone came, let's say this patient came in, and this is after maybe a minute to a few minutes in the ER. You see this, you know that this hasn't been lasting long. But let's say you come by the next day and the PCO2 is still down at 20. You're going to be over here, and you're going to not be able to fit the change in the PCO2 to the change in bicarbonate to either acute respiratory alkalosis or chronic. It's going to look mixed, and we'll talk about that in a little bit. The lack of the predicted change, or one of the three that would be causing the fall if it were simple acid-base disorders, means that either you're in between the final steady state and it's still a simple acid-base disorder, and you're fooled into thinking that it's mixed, or it truly is mixed and you're over here. So it can be confusing if you haven't reached a new steady state. And the problem is, if you don't know time zero, like if you saw the patient here in the ER and they were admitted, you know when time zero is. So you know 3 or 4 days from now, it should fall. If the PCO2 is kept at 20, you know the bicarbonate's going to be around 20. But if you don't have this initial value and they just came in here at this point, you don't know what the reason is. You'd have to hypothesize that it's in between the acute and chronic. You may get a clinical history that tells you when time zero is. That might help. Okay, so the change in the bicarbonate takes time. Now, this is an example of a new steady state of chronic respiratory alkalosis that we showed last week. 24-year-old female in the 3rd trimester of pregnancy. Remember, all females in the 3rd trimester of pregnancy have a chronic respiratory alkalosis. They hyperventilate. And that started earlier, but it reaches its new steady state in the 3rd trimester. And so here's someone with a PCO2 of 20, and the bicarbonate fell by half. It fell by 10. Okay, so it fell the initial amount and then fell a further amount after that. So again, when you see this, you know it just didn't occur. You know temporally that this has been going on for at least 3-4 days. Otherwise, you couldn't have double the fall in the PCO2 than the bicarbonate fell. I think in this last case, I said that this would fall to 20. It actually would fall to 10 less, so it would be to 15. I misspoke there. So if this had fallen to 30, then this would fall to 20. So remember, it's 2 to 1. Because this is 20, this would fall in the new steady state by 10. So it falls another 7 from its original value due to the kidney. So going back to here, this woman has already gone through this. She's already gone through the acute phase. You don't know when that started. And she could have been in this state for weeks and weeks and weeks. It doesn't keep falling further and further. Once you reach this level, it just stays there. So as I said before, probably the most common cause of chronic respiratory alkalosis on the earth is women in the 3rd trimester of pregnancy. The next most common probably is people that live at high altitude. So after about 3,000 feet, you start getting noticeable changes in the acid-base status where you get chronic respiratory alkalosis. Probably the 3rd most common is end-stage liver disease or chronic liver disease like we have in our hospital. Of course, they can get many other acid-base disorders, also patients with liver disease, and they can be mixed also. But in general, they get a chronic respiratory alkalosis because it's not well understood, but it's thought to be the same mechanism as pregnancy, where the progesterone level goes up and it drives the medulla to ventilate more. Clearly, with elevation, it's not due to progesterone, it's due to hypoxia. Another clue, which is not shown here as far as the temporal changes, whether it's acute or chronic, is you tend to get hypophosphatemia when you have acute respiratory alkalosis, whereas when it's chronic, the phosphate after the initial fall tends to come back to normal again. The acute fall is because when you drop the PCO2, you alkalinize the cells acutely, right? You're not just alkalinizing the extracellular fluid. We tend to always think of what's going on in the blood, but these acid-base changes affect all cellular compartments, including the intracellular compartment, and the glycolytic pathway is pH sensitive. So there's an enzyme that in glycolysis that when you raise the pH inside will drive glycolysis. And what happens is you increase the amount of phosphorylated intermediates in those organic compounds, and phosphate just goes into the cells to be bound to these compounds in the cell. Whereas when you start dropping the bicarbonate, the intracellular pH and the extracellular pH, by the way, start becoming less alkaline, start becoming closer to normal. And so you lose that hypophosphatemia. Okay, so that if you see these numbers and a drop in phosphorus, you don't need the drop in phosphorus because these numbers alone already tell you, but you can really lower someone's blood phosphorus by just hyperventilating. I mean, if you started hyperventilating right now during this talk, your phosphorus is your phosphate is dropping. And it's again because it's shifting into cells. Okay, so in the last number of talks, we've covered the simple acid-base disorders. We'll now segue to mixed disorders, and we'll go back and forth over the subsequent weeks, but I thought I would just briefly allude to how do we know we have a mixed disorder? And there are a number of different categories to think about. One is, as I mentioned, it may not truly be a mixed disorder. You may not be in the steady state. As I said before, it could be you're over here. You wouldn't call that a mixed disorder chemically per se. It's still a respiratory alkalosis only. It's just you're between acute and chronic. So it's not truly a mixed disorder, but it looks like one because it doesn't fit either acute or chronic. Another clue that you have a mixed acid-base disorder is when you take the change in the anion gap and you add it to the current bicarbonate. Remember, we talked about, people talk about the delta-delta gap, and there's so many assumptions in that, but it's done to answer one question: what is the previous bicarbonate concentration? So people take the change in the anion gap and add it to the current bicarbonate and end up with a number. And if the world was perfect and the volume of distribution of the protons and the organic anions and the excretion of these things was equal from the body, then you would expect that the change in the anion gap should equal the fall in the bicarbonate. So when you add the increase in the anion gap from normal to the current bicarbonate, you should get the original bicarbonate. And so if you get a number that's greater than normal, it suggests that you had another acid-base disorder present, either a metabolic alkalosis or a chronic respiratory or acute respiratory acidosis, something that would elevate the bicarbonate. Again, even though tendings love to show this, the ones who are interested in acid-base, and it's in the textbooks, in real life, the change in the anion gap does not equal the fall in the bicarbonate because there's different volumes of distribution. The kidney, in some situations, doesn't absorb the anions normally, or does absorb them normally, and so that affects the change in the anion gap too. Remember that the anion gap that you get is not just due to the anions coming into the blood. It's due to how well the kidney can excrete them. If the kidney can't excrete them, then it's only due to the input. But if the kidney can excrete them, that's going to lower your anion gap, even though your input is the same as another person. You have someone with end-stage renal disease with ketoacidosis who's putting in X amount of ketone bodies. The anion gap's going to go up more than someone who's got normal renal function because the ketones are going to be excreted in the one with normal renal function to some extent. So for the same input, the same degree of ketoacidosis, the same degree of everything else being the same insulin deficiency, same amount of hyperglycemia, the anion gap's going to go up more in the patient that can't excrete the anions. So you have to start thinking about changes in blood levels, not due to either an abnormality on input or an abnormality on output. It also depends on the input. For instance, if you have, let's say, someone on spironolactone or type 4 RTA, they can have a totally different potassium level, even though you've decreased their kidney's ability to get rid of potassium to the same extent, just based on changing their potassium intake. You put two patients on different potassium intakes with the same degree of impairment of potassium excretion. The one on the higher K intake is going to have a higher potassium. It has nothing to do with what the kidney's doing. So you always in nephrology have to think of input and output when you're assessing something. So getting back to the mixed disorders, you could have normal numbers, and we'll show that in a minute, but normal numbers do not mean that you don't have an acid-base disorder. We'll talk about that in a minute. The other concept is in metabolic acidosis or alkalosis, when you don't have the appropriate compensation, by definition, you have a mixed disorder. So if you have a metabolic acidosis and the PCO2 doesn't follow the Winter's formula or it doesn't follow the 1-to-1 rule, that's not sufficient to say to someone else, my patient's not compensating properly. You have to also say my patient has either a respiratory acidosis or alkalosis. If it's above what you'd expect, it's a respiratory acidosis. If the PCO2 is below what you expect, it's a respiratory alkalosis. But you have to recognize immediately that the lack of an appropriate compensation means you have another it means you have a respiratory acid-base disorder, in addition to what the metabolic diagnosis was. Same thing with metabolic alkalosis. You look at the PCO2, if it's not what you predict, by definition, you have a respiratory acid-base disorder. Whether it's acidosis, it would have to be above what you predict. Alkalosis, below what you predict. Same thinking. So remember that when you look for the compensation in metabolic acid-base disorders, don't just write on the chart it's not compensated. That's very nice to say, but you're missing that it's a mixed disorder, and you're missing stating what the disorder is. It's always respiratory if it's not compensating, but you have to state which it is, respiratory alkalosis or acidosis. Whether it's acute or chronic gets into more subtleties, which we'll talk about, but at least say that it's a respiratory acid-base disorder, and which one. In your mind, you're thinking, is this acute or chronic, right? Because when you say it's a respiratory acid-base disorder, you have to further subdivide it. Okay, so let's look at these numbers now. Here's a 70-year-old male who was vomiting with end-stage renal disease. There's some dysnatremia, hypokalemia. There's elevated BUN and creatinine, as we would expect. Patient's end-stage renal disease. And we look at these numbers, including the total CO2, and everything looks normal. So I'd like to open the floor now. Does anyone want to unmute and tell me what they think might be going on? Is there an acid-base disorder? Is the question, and this could be on your boards. Anyone have any thoughts as to what might be going on here? Would you say the patient has acid-base? You know that it can't be a simple acid-base disorder, because you can't have a simple acid-base disorder with these numbers. So whenever you see normal numbers, you have to think, is it normal like it would be 90% of the time? Or is there acid-base disorders here that I need to figure out and recognize? Does anyone want to take the floor? Yeah, go ahead. Yeah.
Yeah. So if he has ESRD, would we actually expect him to have generally a chronic metabolic acidosis? And so in this case, we would look at it as if he likely has some sort of mixed pathology, something mixed that incorporates a metabolic alkalosis.
Okay, so you have a number of points there, and we'll go through each one. You can approach it medically like you're doing and say, from these diagnoses, I would expect this, and since it's not there, then logically there must be a reason for it. That's one way to do it. And that would be more of an adjunct to looking at the numbers. So I would always approach it numerically first and forget the clinical. So without any clinical at all, you need to be able to make the diagnosis. The clinical should be an adjunct, but not your starting point for making the analysis. That's point number one. Point number two, you use the word chronic metabolic acidosis. We never use the word chronic. We don't have a temporal term in metabolic acid-based disorders, only with the respiratory. Now, number three, you are exactly correct. When you have a patient with ESRD, yes, you would expect a metabolic acidosis, and the fact that there isn't one means that there must be something elevating the bicarbonate to normal. Now, I must say, everyone, and so your logic is impeccable. I must say that, as you will learn with time, there's another reason for the bicarbonate being elevated back to normal that everyone ignores. Everyone says it could be metabolic alkalosis, but remember, respiratory acidosis could also be returning this to normal.
Mm-hmm.
Now it can't. Now you look at the PCO2 and you go, well, that doesn't make sense, Dr. Kurtz. The PCO2 is 41, but you could, and we'll do this in later months, you could devise scenarios where there's actually 3 different acid-based disorders here, giving you these numbers. So what you said statistically is correct, but the goal here should be to try to ignore the clinical here and just look at the numbers. There's a clue here that just looking at these numbers, this can't be normality.
Oh, the hypochloremia?
Well, that's one way of saying it. That's one way of saying it. We don't typically, and it's a component of the math you need to do. So yes, the chloride is low, but we don't tend to focus in on that diagnostically in medicine. It doesn't lead us to anything. I mean, yes, empirically it's true. The chloride's lower, but it's lower because of something.
The anion gap
Yes, that's right. So the anion gap here's elevated. You have a patient with an elevated anion gap with a normal bicarbonate. So that's what you need to go in with laser initially. And that alone will allow you to then go to the next logical step. So, and the reason the chloride is low when you have an elevated anion gap is because you have to maintain electroneutrality. Your blood can't spark, it can't be a battery, right? So whatever the anions, the negatively charged anions went up, the chloride goes down. So the total of the bicarbonate, the chloride, and the anions remains the same number as before. Whereas when you don't have anions coming in and the bicarbonate falls, the chloride goes up by whatever the bicarbonate fell. And we say, okay, the anion gap's normal. But remember, the bicarbonate, chloride, and all the other anions added up together are always the same number. We just play with them in medicine. The bicarbonate falls, the chloride goes up. Okay, non-gap or hyperchloremic metabolic acidosis. The anions come in with a proton, the bicarbonate falls, the anion concentration goes up and the chloride stays the same. Okay, so, but here there's something else going on. So you have an elevated anion gap, but the bicarbonate is normal. So it's sort of weird. You have a normal bicarbonate, the anions went up, the chloride must fall, right, to maintain electroneutrality. You don't have a change in bicarbonate here. So this is sort of a weird situation. So then you have to think conceptually and pathophysiologically. How could you have the anion gap going up, but the bicarbonate's normal, when you never just have anions coming in, right? With a lactic acidosis, you don't just have lactate coming into the blood. With ketoacidosis, you don't just have beta hydroxybutyrate and acetoacetate coming into the blood. You don't just have an anion coming in. These processes also have to maintain electroneutrality. So how can you have lactate coming in and maintain electroneutrality? It either has to come in with sodium, potassium, some cation. And in medicine, it comes in with a proton. The endogenous biochemical reactions in our body don't use so-called fixed cations like sodium and potassium. We could have evolved that way, but we didn't. So when the lactate comes out of the cells, a proton comes with it. And the same with ketoacidosis. And it's the proton which causes the metabolic acidosis, not the anion. The lactate does nothing when it's not metabolic. It just comes into the blood. It's the proton that binds bicarbonate, and we get this reaction occurring. The proton binds bicarbonate and shifts the reaction this way, but now we have a lower bicarbonate concentration. And again, the proton doesn't go up by what the bicarbonate fell, because other buffers take up some of that proton load from lactate with the proton. They don't all, not all the protons consume bicarbonate. In fact, the vast majority don't. Most of the protons that come in with the lactate are buffered by other buffers. They bind to DNA, bind to phosphate, bind to hemoglobin, bind to amino acids. Okay, so what is going on here? If we say the anion gap went up, and this is an endogenous process in the body, it must have occurred with a proton. So how can we have a proton coming into the body and the bicarbonate's still normal? Well, like you were alluding to, there must be another process which elevated the bicarbonate. And again, you can't, I didn't say before, you can't tell temporally. Don't make the mistake of saying this occurred first and then this occurred. There's no movie here. This is a photograph. This is a snapshot in time. So we don't know what was first, whether the patient had an elevated bicarbonate first, or the bicarbonate dropped first and then the bicarbonate came back to normal. You'll never know that just from one set of numbers. And people often make that mistake. They start talking about a movie with just one snapshot of numbers. You can only do that if you have clinical history. So if you knew, as you were alluding to, now you look at the clinical, that there was ESRD and then the patient started to vomit, then you can hypothesize that there was likely an anion gap metabolic acidosis from the ESRD, and the patient's vomiting raised the bicarbonate and returned the bicarbonate to a normal value. And again, this is just fortuitous. Doesn't have what you say from this is that the magnitude, if you are right that there's a chronic anion gap or that there's an anion gap metabolic acidosis and vomiting causing a metabolic alkalosis, you know, and you tell another person, you teach the medical student and the resident that they must be of equal magnitude. So the metabolic process that is tending to lower the bicarbonate must be quantitatively identical to the vomiting process, which is tending to raise it. And just fortuitously, you end up with a normal bicarbonate. Now, you're not going to have any ventilatory changes, because remember, the ventilation is going to return to normal too. If it was a movie and the metabolic acidosis occurred first, yes, the PCO2 would have been down from a compensatory response. But as soon as the vomiting started, the bicarbonate's now returning to normal. And once it returns to normal, you're not going to get any, the PCO2 comes back to normal, right? You lose the compensation. There's no reason a priori to have it once you have a normal bicarbonate, just like when your bicarbonate's normal, your PCO2 is around 40. So basically all the numbers were returned to normal. And if you miss checking the anion gap, you're going to just say, you're not even going to notice this. So this is just a lesson that normal numbers do not mean the lack of an acid-base disorder. Now, do we know that this was vomiting doing it if we don't have the history of vomiting? No. If you have a normal bicarbonate and you know you had a metabolic acidosis, whether it's a gap or non-gap, you have some process elevating the bicarbonate, but unless you go further into the analysis, and we'll do that in future talks, you cannot say whether it's metabolic alkalosis. Now, typically on an exam, they give you someone who's vomiting with a cause for a metabolic acidosis too. But if this, for instance, was diarrhea, let's say the patient had a non-gap metabolic acidosis and was vomiting, you wouldn't even have an elevated anion gap. Everything would look normal. You'd have a normal anion gap and normal acid-base numbers. And then the only way to do it would be one clue, and that would be you probably would see dysnatremia and hypokalemia. So that alone tells you something's going on. And then you would have the history, as you were alluding to, that the patient, hopefully the patient had diarrhea and vomiting. But remember, someone with a non-gap metabolic acidosis who's got a metabolic alkalosis and they're equal in magnitude will have totally normal numbers and a normal anion gap. Okay, so remember the bicarbonate goes up from vomiting because you lose more protons into the stomach, into the lumen of the stomach in exchange for potassium. This is the proton potassium ATPase. This is omeprazole. Proton pump inhibitors block this. But remember, you generate a bicarbonate ion. I didn't show the whole reaction here. It's the same one that I showed before, but you create a disequilibrium, out of equilibrium reaction, and you generate bicarbonate. The bicarbonate has to go somewhere. If it went into the lumen, nothing would happen, but the bicarbonate leaves on the basolateral side of the parietal cell on a anion exchanger, call it AE2. It's one of the chloride bicarbonate exchangers in your genome, and it goes into your gastric vein, and it elevates the bicarbonate, at least transiently. And if you have ESRD, it's going to elevate it even more, as we talked about. Remember, if I give you a bicarbonate load, you tend to excrete it. That's the alkaline tide. Your bicarbonate doesn't stay elevated because the kidney dumps it. But if you have a situation where you're volume depleted and your proximal tubule is hyperabsorbing bicarbonate, or you have ESRD and you can't even filter it, then you're just going to have this elevate your blood bicarbonate to a higher extent. And then remember also why ESRD causes a metabolic acidosis. It causes it because you don't take up glutamine into the proximal tubule cells normally to generate new bicarbonate like you did normally. Remember that we match our daily hepatic proton load with this new renal bicarbonate generation in the proximal tubule. There are other components too, but this is the main one that's affected in end-stage renal disease and CKD. This is the cause of the metabolic acidosis. So if someone says to you, why is the bicarb low in my patient with CKD 4 or 5 or ESRD? The answer is my patient cannot take up glutamine normally, converted in the Krebs cycle to 2 bicarbonate ions. Now you could change the diet and lower the daily hepatic proton load by putting someone on dietary proteins or lower their protein intake so that they won't generate as much protons, but then you're dealing with other problems as far as their biochemistry and muscle mass, et cetera, et cetera, et cetera. So just as far as conceptually what's going on, this is what's going on. And this is the same reason why the ammonium excretion rate in someone with ESRD is lower than normal. They're not able to generate ammonia from this reaction normally. And again, this, remember, is something that's a byproduct that actually consumes the bicarbonate in the urea cycle. But the key is that the glutamine, it's been known for many, many years that the glutamine uptake by patients with CKD and ESRD is very poor as you lose more and more renal mass and get destruction of proximal tubule tissues. This is a reaction that occurs predominantly in the proximal tubule. So I think we'll finish with this case. This is another mixed case of a 33-year-old male with heart failure on Lasix, and you look at these numbers, and again, dysnatremia, some hypokalemia as we would expect from the Lasix. There's some pre-renal failure. The BUN creatinine ratio is high. The total CO2 is elevated by about 10, compatible with the bicarbonate on the blood gases. It's up about 9 or so, 9 or 10. And so again, we're dealing with either a metabolic alkalosis or acute or chronic respiratory acidosis. Those are the 3 reasons for the bicarbonate being elevated. We look at the PCO2 change and we see that it's up about 0.7 above relative to what the bicarbonate went up by. And you don't even have to look at acute or chronic respiratory alkalosis because this is compatible with a compensated metabolic alkalosis. So the simple acid-base disorder here. Okay, and now the patient was in the hospital for 4 hours and developed shortness of breath, and 4 hours later, these are the new numbers. So what you see here now is that the PCO2 has gone from 47 to 67, and the bicarbonate went from 34 to 37. So the bicarbonate's up further, so this is either due to a worsening metabolic alkalosis or acute or chronic respiratory acidosis. Well, it clearly can't be due to metabolic alkalosis, because if it was metabolic alkalosis and this went up by 3, the PCO2 should have, to compensate, should have gone up 0.7 of that, which is about 2.1 or something. So this should have gone to 49. And so clearly that didn't happen. So you're dealing with a respiratory acidosis, and it's either acute or chronic. So you just look at the change in the PCO2 relative to the change in bicarbonate from these numbers. This is you don't go by the population normal numbers, you go by from what it was 3-4 hours ago. So does anyone want to tell me whether this is acute or chronic respiratory acidosis? Nothing fancy. You just have to remember the rule. For every 10 increase in the PCO2, how much does the bicarbonate go up in acute respiratory acidosis? Anyone remember? Yeah, these rules you really need to start memorizing. It should be second nature, because if you don't, you're always going to be wondering. You just have to spend an hour, memorize the rules, or keep them on your phone. But so the PCO2 went up by 20. So the bicarbonate should go up 1 to 2. And it did, went up by another 3. So you don't even have to think that this is chronic respiratory acidosis. And you know it can't be a priori because you only spent 4 hours at this. Well, you hypothesize it's 4 hours. You know the patient was short of breath for 4 hours. You don't know exactly when this started. But again, respiratory acidosis, the final slowing down or stopping of the change in bicarbonate takes 4 or 5 days. And this has been so this even temporarily, this can't be chronic respiratory acidosis. So here's a patient with a metabolic alkalosis that was compensated and now has a mixed disorder. Metabolic alkalosis didn't go away, can't go away that fast, but there's a new acid-base disorder in addition. Now, we don't use the word superimposed. You find people using that all the time. Just rid your brain of that word. They're just both present. When you write on the chart the acid-base diagnosis, you write down patient had originally a compensated metabolic alkalosis, and then in the hospital, in addition, developed an acute respiratory acidosis. For some reason, I mean, these numbers don't tell you why the patient's ventilation acutely decreased. Okay, I think we'll stop there for today.